Sorry for the delay. Today has been quite a busy day actually. Okay, all right. Okay, what's the topic today? What's the you know what we're doing this afternoon?
Case-based learning.
Okay, all right. So this is how many sessions have you got? Case-based learning.
This is the first one.
This is the first one. Okay, all right. If you notice, every lecturer will do different things, but that's fine. Difference means more variety, more exposure to you. That's fine. Well, it's not ideal. Ideally, you should be practicing with patient rather than discussing like this. But I think there's nothing much that we can do lah. So I think whatever we have, we will do our best. Okay, all right. Before we begin, let me ask you something. As medical students, so in year 3, how many postings have you gone through?
So far, 3.
So far?
3.
3. What is it? What is it that you have done?
ONG, surgery, pediatrics.
Okay, all right. Okay. So let me ask you, when you clerk patient, when you clerk patient, you get the history, and then you do physical examination, and then you present those cases, isn't it? So and as doctors, you'll be clerking patients your whole life. You'll be investigating. You'll be examining patients your whole life. You'll be presenting cases your whole life. So my question to you is, what is the objective? Why? What are we trying to achieve? When you clerk patient, when you get history from patient, when you examine a patient, when you present the case later on, what are your objectives? What is your goal? Ada 4 objektif. Can anyone try and guess? Or if anyone watched the previous group ni video mesti tahu dah lah.
To get the provisional diagnosis.
Yes, so that's the first objective. To get to your provisional diagnosis. To sell your, when you present is to sell your provisional diagnosis. When you clerk, when you examine patient, is basically to get to your provisional diagnosis. Every detail about the provisional diagnosis. So from your clerking, you need to be able to understand the progression of the provisional diagnosis. You need to be able to diagnose, because 80% of diagnosis is you will get 80% of diagnosis by history alone. So from your history, from your physical examination, and when you present, it should show towards, it should focus, it should get to your provisional diagnosis. The one who listens to your presentation should understand without you even saying. They should know that, okay, this is the provisional diagnosis that you are selling. So your history, your physical examination should have all the positives and all the negatives pertaining to your provisional diagnosis. You should have the timeline, the natural progression of the disease, and so on and so forth. Because why? Because when we treat patient, we will treat based on the provisional diagnosis. When we discuss, when we counsel, when we say what's the prognosis, it will depend on the provisional diagnosis. So knowing the provisional diagnosis is extremely important, because that is how you are going to go forward. Without knowing the provisional diagnosis, you will not be able to manage the patient. You can only know what to give. For example, if a child presents with hyponatremia, do you want to give sodium, or do you want to give fluid, or you want to restrict fluid? Hyponatremia. The diagnosis can either be SIADH, or cerebral salt wasting, or adrenal insufficiency, aldosterone insufficiency. Kan? CAH, for example. So the management is different. With SIDH, you will restrict fluid. You'll give furosemide. You'll give diuretics. You restrict fluid. You will not give extra sodium. But if the diagnosis is cerebral salt wasting, then you will need to give fluid. The management differs. So that is why from your history, from your physical examination, it should point towards your provisional diagnosis. So what is the second objective? So that's the first objective. What is the second objective?
To rule out differential diagnosis.
To rule out differential diagnosis. And I expect you all year 3 should have at least 5 differential diagnoses. At least 5 differential diagnoses. So in your history should have adequate history to rule out 5 differential diagnoses. For the disease you kena ada 5. So you must have all the positives and all the negatives for each differential diagnosis. So those that listen to you should be able to know, oh, okay, you are trying to rule this out, you're trying to rule this out, and this is very unlikely, this is very unlikely. So your history, your physical examination, and your presentation nanti should rule out at least 5 differential diagnoses. Okay, what is the third objective?
To look for the complication of the disease.
To look for complications of the disease. Good, bagus. Someone has read from somewhere or listened from somewhere before. Excellent. Yeah, so the third objective is to look for complications of the disease. Because all disease has complication. Nothing in this world do not have any complication. So your history, you need to look for the complication of the disease. If you think it is hyponatremia because of SIDH, so look for the complications of SIDH. Look for the complications of hyponatremia. What are the potential things that can happen? If your diagnosis is asthma, what are the complications of status asthmaticus? What are the complications of it? If your patient has dengue, for example, dengue fever, what is the complication of dengue? You need to go through all those things. So your history, your physical examination should look for those things. If you think it's dengue, you need to look for signs of shock, signs of bleeding, and so on and so forth. So you need to look for the complications. So that is why you need to know what are the complications of the disease. Because if you do not know what are the complications, how can you know what to ask? And you may ask, apa masalah lagi? Kan? That is very general, very vague. Kan? Sometimes you need to go through a bit more close, targeted question. It's not just close, but close, targeted question. Or open, targeted question. Okay, that's the third objective. What is the fourth objective? What is the fourth objective?
To determine the treatment.
No?
Complication of the management.
Complications of the management. Because everything that you do to the patient or everything that anyone do to the patient has its own complication. Nothing in this world do not have any complication. Minum air kosong pun ada complication. Kan? And not doing anything pun ada complication. Not doing anything. Apa mak buat? Tak buat apa-apa. Apa doktor buat? Doktor tak buat apa-apa. Not doing anything has complication. So in your history, in your physical examination, you need to look for the complications of those management. Faham? For example, if you clerk a patient on day of admission, tetapi on day of admission tu, the patient already has the problem for 5 days, for example. Let's say a child, your diagnosis is asthma, the patient already has this exacerbation for the past 5 days. Symptom tu dah 5 days. Do you think the mother will do nothing for the past 5 days? Definitely the mother would have done something. Kalau dia ada fever, mother would give antipyretics, isn't it? Paracetamol. Paracetamol has complication. The patient is tachypneic, wheezing. the mother would have given something. The mother would at least be giving the rescue MDI, kan? MDI salbutamol has complication, kan? Maybe they brought the patient to clinic already. Clinic may have started some medication, and those medication has its own complication. Salbutamol ada apa complication salbutamol? For example,
Tachycardia.
tachycardia, yes. Lagi
Palpitation.
palpitation lagi.
Increase blood pressure.
Dry mouth. Dry mouth.
Dry mouth, okay. Lagi
Edema.
edema, no. Arrhythmias, tremors, hypokalemia. Hypokalemia. So those are among the complications of salbutamol. So salbutamol has complications. So if your patient was given salbutamol, you need to look for what are the complications that has happened. This is at home, kan? For example, patient datang dengan febrile seizure, kan? Mak mesti buat something. Takkan mak ignore je, anak tengah seizure, biar je. Kan? Mother must have done something. And that something has its own complication. So your history, your physical examination, and when you present later on, it should conclude, it should include, it should tell us what are the complications of the management. And not just at home. For example, when you clerk the patient in ward, the patient dia bukan masuk direct ke ward, dia pergi ED dulu kan. So something must have been done in ED. Takkan masuk ED tak ada apa buat, doktor tengok, oh okay, bagus, terus naik atas. Tak ada kan? No, they must have done something. And that something has its own complication. Apa buat kat ED? Berapa lama dekat ED? Kan? Patient yang lama dekat ED, dekat emergency department, you know something is being done, lama kat bawah. Kan? Ataupun dekat ED tu banyak line pasang sampai 3. So you know the patient probably comes in a very bad condition. Kan? Apa buat dekat ED? Tapi kalau patient sekejap kat ED turun naik atas, probably it's not that severe. Kan? Sometimes you do not clerk the patient on day of admission. Sometimes you clerk the patient on day 14 of admission, for example. Patient meningitis, last day of antibiotic. Kan? 14 days of being in the hospital. Must be a lot of things being done, kan? At least pasang line. Line ada complication, thrombophlebitis, kan? Dapat nosocomial infection. So many things can happen. So in your history, your physical examination, and when you present later on, you should include the possible complications of all the management that has been done from the point where you clerk the patient. Okay, all right, fine, clear. So those are the 4 objectives of clerking a patient: physical examination and presentation. To get to your provisional diagnosis, because that is how you manage. To rule out differential diagnosis, which is very important for you to make sure you're not missing things, and for you to have a thorough history, you need to have good differential diagnosis. Again, I always tell students, the problem with your history is usually you don't know what are the differential diagnosis. When you do not have strong differential diagnosis, you do not know what are the questions you can ask, you should ask. So that is why always have good differential diagnosis. And third is complications of the disease, because all disease has complication. And fourth is complications of the management of the treatment, because everything that you do may have complication, and as you're going to manage the patient, you need to know what are the complications that has happened. Okay, all right, fine. Let me grab a pen. Okay, so what we'll do today is let us do this. Sorry. Okay, I'll start with with a generic problem, with a generic presentation, and then what I want from you all is probably tell me first history. We'll go one round history, and then we'll go another round with physical examination. From this chief complaint, what are the questions that you would want to ask? Okay, then I'll tell you what are the answers. Okay, this is a patient that was admitted yesterday night. Okay, so you have a 4 years old girl. 4 years old girl presented with periorbital puffiness. Okay, 4 years old girl presented with periorbital puffiness. So what are the questions that you would want to ask? So okay, let's go through list according to my screen here. So we'll begin with Nurhanis Amirah, lepas tu Faiz Imran, lepas tu Taufik Fauzi, lepas tu Nazril Haziq, Hafiz Syafi'i, Ilya Maisarah, Alisa Nabila, Nur Fatin Atirah, Aina Izzati, dan Nur Hafira. Okay, alright. So, Hanis, Nurhanis Amira, question.
I would like to ask, when does when you notice the puffiness start?
Okay, the mother said the mother noticed increasing facial puffiness for the past 3 days.
Okay.
Okay, next, Faiz Imran.
Sorry. Do you notice does the puffiness go away or does it stay there?
It's worsening by day.
Did anything happen before the
Worsen, they're worse in the morning. Worse in the morning, a bit less in the afternoon. Okay, alright, Taufik.
Did the patient have any unusual exposure to insects or bugs?
What do you mean by unusual exposure? Is there a usual exposure? What do you mean by usual exposure to bugs?
Okay, exposure to insects or bugs.
What do you mean by exposure to insects or bugs? Is that what do you mean by exposed?
Bitten or stung.
You ask proper terus lah. Because exposure means anyone is not exposed to bug dalam ni. Bugs is everywhere in Malaysia kan. No one is not exposed to bug. Kan? So no history of insect bite if you're thinking about that. Because exposure is something. You may be exposed but you're not bitten. So no history of insect bite. Nazril.
Okay, I want to ask, can you describe the facial puffiness? Is it soft or ada redness ke dekat kawasan tu?
Soft, is it a history of physical examination? Is it history of physical examination? When you are soft.
Hello. Okay. Sorry, my internet is not it's not stable. Okay. Okay. I want to ask if there are any areas that have swelling too. Ada swelling dekat kaki ke, ada kat tangan ke?
Okay, there is some ankle swelling. Okay, alright, Hafiz.
Is there any history of infection, for example, fever, before the onset?
No. Ilya?
Does the swelling disrupt the daily activity of the patient?
Nope. Alisa?
Does the patient has a history of what pharyngitis before, or any sore throat ke yang boleh suggestive of pharyngitis.
No, patient didn't complain if anything. But there is reduced feeding. Okay, Fatin?
I want to ask, does she has any history of allergy?
No, no history of allergy. Aina?
I want to ask if the swelling is painful and if it is accompanied by any discharge from the eye.
No, it's not painful. It's non-painful and there's no discharge. Nur Hafira?
I want to ask about her urine output. I mean the amount, the volume of her urine.
A mother says the urine is reduced. Frequency is reduced. Okay, right. Let's open to the floor. What are other questions that you would want to know?
Does he have fever?
Fever answered already.
Oh.
No fever.
Shortness of breath.
No fever.
Huh?
Symptoms of
Shortness of breath.
No shortness of breath.
any symptoms of heart failure like orthopnea, easy fatigue or exercise intolerance?
Reduced temperature. No. It's just generally the patient seems to be more lethargic than usual.
Does he
Ask about
feel?
Yeah,
the characteristic of the urine. I mean, is it clear, the color, the content and all?
Good question. The urine seems to be bubbly. Banyak apa? Buih.
Does he feel any pain at the back?
No, there's no pain. Anything else? Frothy urine. Anything else? Again. Provisional differential complication. Provisional differential complication. Have you got enough information? Okay, what are the things that you should ask?
Ada hematuria tak?
How would you ask that question?
Maksudnya macam masa anak kencing ada macam darah tak dekat air kencing? Ataupun
No.
sakit waktu kencing?
It's frothy, it's not painful, but there's no blood. Lagi? Provisional differential complication.
Patient has shortness of breath.
Answered already. Ask and answered already. No.
Ada macam sakit-sakit dekat perut bahagian abdominal ke?
No abdominal pain. No pain anywhere. The only
Ada ambil
pain.
ubat tak?
Ubat tak ada
ambil
lagi.
ubat tak?
Tak ada lagi.
Has this occurred before?
No. First episode.
Ada apa-apa penyakit lain ke?
Tak ada. Okay, fine. Okay, let's go one by one. Tell us, what do you think is your provisional and differential diagnosis from what the information that we have got?
Nephrotic syndrome.
Post-streptococcal glomerulonephritis.
Nephrotic syndrome.
Mari kita go one by one. Start daripada Hanis juga. Tell me your provisional diagnosis and differential diagnosis.
Provisional is nephrotic syndrome. For the differential, it's post-streptococcal glomerulonephritis, and then acute glomerulonephritis, minimal changes. Again.
Lagi? Tu berapa je tu differential? Sekejap. Satu. Sekejap sorry, ada hospital call. Okay, Faiz.
My provisional, I thought would be a nephrotic syndrome due to kidney injury due to kidney complication due to diabetes mellitus.
Why you think it's diabetes?
I want to think it's infection, but then there's no fever or any pain, suprapubic or back pain.
So why diabetes then?
Oh yeah, he doesn't have much urine. I'm not sure. I just know I only think it's a kidney problem. I think.
Okay,
Differential would be just provisional would be glomerulonephritis, and then for my provisional, maybe just UTI or acute kidney injury due to dehydration. That's all.
Lagi? Baru berapa?
3. Minimal change disease and focal sclerotic glomerulonephritic syndrome, FSGS.
Focal segmental.
Focal segmental
Okay, alright,
glomerulonephritis.
Perfect.
My provisional diagnosis would be nephrotic syndrome, and other differentials, glomerulonephritis, minimal change disease.
Hi, this is a problem. Okay, you said that nephrotic syndrome. Lepas tu minimal change, ni sama lah. Faiz pun sama. Hanis pun lebih kurang je. How do you define what are the causes of nephrotic syndrome?
Minimal change disease.
So nephrotic syndrome, you divide into primary or secondary. Primary nephrotic syndrome, 80% of all nephrotic syndrome is actually minimal change. 80 to 90% of all nephrotic syndrome is minimal change, and minimal change is part of primary nephrotic syndrome. The other primary nephrotic syndrome are membranous glomerulonephritis and focal segmental glomerulosclerosis, FSGS, and membranoproliferative nephrotic syndrome. These are primary nephrotic syndrome, and there are secondary causes of nephrotic syndrome. For example, apa? Siapa boleh cakap what are the causes for secondary nephrotic syndrome?
SLE.
SLE, yes, lupus nephritis. Lagi?
Henoch-Schwann line purpura.
HSP, yes, HSP go into glomerulonephritis, lepas jadi nephrotic syndrome. Lagi?
Hep B infection.
Apa?
hepatitis B infection.
Yes, okay, alright, lagi.
Diabetes.
Diabetes, yes, okay, lagi.
Pasture
Drug
syndrome.
Ha?
Drug-induced.
Tak dengar.
Drug-induced.
Contoh drug? Betul, tapi contoh dah.
Corticosteroid, diuretics.
Steroid causing nephrotic syndrome. No. Steroid is the treatment for nephrotic syndrome.
NSAID.
Huh?
NSAID.
NSAID causing nephrotic syndrome. Not really.
ACE inhibitors.
Metals, heavy metals. Okay, alright. Lagi apa lagi? What else?
Good pasture syndrome.
Okay, rare lagi.
HIV.
HIV, yes. And then name me one genetic causes. Mainly in male. Ada renal impairment juga.
Alport syndrome.
Alport syndrome, yes, excellent. Alport syndrome. So these are secondary. Okay, name me one type of food that causes nephrotic syndrome. Starts with J or DJ. Malaysia punya start with J lah.
Jambu.
Jering, jering or jengkol in English or in Indonesian or basically in Dutch lah dia panggil jengkol. So jengkol nephropathy. Okay, so these are the secondary causes of nephrotic syndrome. So majority of nephrotic syndrome, huge majority of nephrotic syndrome is actually primary, and 80 to 90% is actually minimal change disease. So you tak boleh lah diagnosis nephrotic syndrome, differential minimal change. Dia macam you are trying to tell us that I don't quite know actually, bedal dia. Okay, alright, apa Taufik? Next, Nazril. Nazril.
I think for my provisional diagnosis, I would go for nephritis. Hello?
Macam mana?
Hello?
You punya internet ni problem.
For my provisional diagnosis, petang-petang dia macam slow sikit. For provisional diagnosis, I would go for nephrotic syndrome.
Okay.
And for the differential diagnosis, maybe chronic kidney disease.
Okay.
And then maybe liver failure.
Okay, lagi?
Then maybe post streptococcal glomerular nephritis.
Okay.
Then I think I would go for maybe congestive heart failure.
Okay, why and why not? Do you have enough information tak?
I think for heart failure, the facial swelling and ankle swelling.
Okay lah, fine. Hafiz.
For provisional, I think it's nephrotic syndrome. For differential diagnosis, acute glomerular nephritis, nephritic syndrome, acute kidney injury, heart failure, and allergy reaction.
Okay, alright. Ilya?
For my provisional diagnosis, I also go with the nephrotic syndrome. And acute glomerulonephritis, chronic kidney disease, diabetic.
Okay, Alisa. And then Fatin, Aina, and then Nur Hafira.
Provisional diagnosis, nephrotic syndrome, differential acute glomerulonephritis, chronic liver disease, heart failure juga, allergic reaction.
Okay, what are the negative for liver disease?
Macam tak cukup lagi saya history.
Apa yang you perlu?
Abdominal swelling ke, and then
Jaundice.
jaundice.
Okay.
Lagi easy bruising.
Stool.
Okay, alright, fine. Okay, Fatin.
Okay, so my provisional diagnosis is nephrotic syndrome, and differential diagnosis acute glomerulonephritis, heart failure, and also maybe there is SLE because this patient is female, so it's most likely. But we need to ask more question about that. And
What are the questions that you would want to know?
Maybe like any joint pain, rash, or swelling, maybe a rash kot, any rash for SLE, and also
Lagi.
SLE.
Orang lain, tolong dia.
Hair loss.
Yes.
Okay, lagi.
Dia rash upon exposure to sunlight.
Photophobia. Okay, lagi. What else? Okay lah, Fatin, next. Apa lagi?
It's less likely about allergic reaction because there is no any significant for allergic, but I just put it any allergic reaction. I think that's all.
Okay, Aina.
I think my provisional would be nephrotic syndrome. And then the differentials include acute glomerulonephritis, can be infection of the skin, cellulitis, allergic reactions, and less likely heart failure.
Okay, lagi.
I think that's it for the.
Okay, Nur Hafira.
My provisional diagnosis would be nephrotic syndrome, and the differential diagnosis include acute kidney injury, acute post-streptococcal glomerulonephritis, angioedema, and less likely allergic reaction.
Okay, lagi.
That's all.
Okay, from what you all have asked, do you think you have got enough information to actually clearly say this is nephrotic syndrome?
No.
Have you got enough information to look for the complications of nephrotic syndrome? What are the complications of nephrotic syndrome? Thrombosis lagi.
Peritonitis.
Spontaneous bacterial peritonitis. Infection. Hypovolemia, shock. So shock is very important. You need to get the history of shock. The thing is, you need to remember something. Sometimes patient may be okay before, but then on the day of admission, patient may present with shock. Patient may present with in a bad condition. So you need to get the information even young, just before arrival to hospital. And what was given in the hospital. Okay, lagi? Apa lagi?
Renal failure.
Renal failure lagi.
Acute kidney.
Tak. Problem with complication of nephrotic syndrome. Ascites, pleural effusion, pericardial effusion. So all these are part of complications of nephrotic syndrome as well. So your history, your physical examination, and when you present should cover nephrotic syndrome, complications of nephrotic syndrome, and differentials. So could it be because it's not anasarca, it's just periorbital puffiness? Could it be AGN? Have you got enough information to say that it is not AGN? Have you asked, okay, there's no hematuria, yes, but sometimes there can still be microscopic hematuria. And there is oliguria. Oliguria is a sign of AGN. Is there hypertension? What are the symptoms of hypertension? Headache, vomiting, kan? What are the so hypertension is a complication of AGN. What are the complications of hypertension pula?
Heart
Confusion.
failure.
Stroke, heart failure. There's so many other complications of hypertension. Kan? So in your history, your physical examination, you need to go through all of this. And if you're thinking of nephrotic syndrome, you know already the treatment will be steroid. Steroid has complications as well. So you need to have a baseline. What are the complications of steroid?
Cushing infection.
Cushing, yes. Kan? So you nak ada baseline. Is there any Cushing God punya feature? Okay, alright. So what I'm trying to say to you is, whatever you have asked now, it is not enough. You need to ask more. You need to get more information. You need to get more history. And what you need to get is the all four. Provisional diagnosis, differential diagnosis, at least 5 differential diagnoses. Complications of the disease and complications of the treatment. Okay, anyone can tell me what is the pathophysiology of nephrotic syndrome? Pathophysiology of nephrotic syndrome, mind you, is a favorite question in exam. If you get me in exam, for, okay, theory exam, we can easily ask. Clinical exam, if you get me for if the patient is nephrotic syndrome, I'll definitely ask you about pathophysiology. Okay, what is the pathophysiology of nephrotic syndrome?
Nephrotic syndrome is characterized by massive proteinuria and also
satu massive proteinuria. Berapa?
More than 40 milligram per meter squared per hour.
Per hour ke per day?
Per hour. And also hypoalbuminemia and hyperlipidemia as well as generalized edema.
Okay, alright. So to definition. 40 milligram per meter squared per hour or 1 gram per meter squared per day, or early morning protein creatinine index of more than 200 millimole per liter per hour. Kan? So you need to know the definition. Okay, so that's the definition, but what is the pathophysiology?
When there is massive proteinuria, you lose proteins, and then there'll be less oncotic pressure in your system. And when there is less oncotic pressure, you will get edema, generalized edema, also particularly in the periorbital swelling. Then at the same time, when you have edema, you will have when you have edema, you will need more to drink, since there is less intravascular volume. Since all the volume from the vessels they keluar, you will feel thirsty.
Bolehlah, kurang best, kurang menarik. So basically what happens first, okay, again as I said, 80%, 80 to 90% is actually minimal change. Why they call it minimal change is because if you do microscopy, you won't see anything. There's no changes at all. It will appear normal. You will only see the problem if you do under electron microscopy. That's why minimal change. So 80 to 90% is minimal change. So what happens is there is inflammation occurring at the glomerular basement membrane, particularly the podocytes and its food processes. So there is effacement of the food processes. So glomerular basement membrane ni dia macam tapis. Dia macam tapis. So dia ada podocyte. So podocyte dia ada food processes dia yang pegang. Dia podocyte dia lubang dia tapis dia dipegang by the food processes. So there is effacement of the food processes. Dia terbuka. So lubang-lubang dia jadi bigger. So bila lubang dia besar, there is effacement of the food processes of the podocytes. Bigger molecule such as albumin boleh pass through. Bigger molecule macam RBC can pass through. Kan? Dia asal dia tapis. Only filter out small molecules. Tapi bila there is effacement of the podocyte food processes, so bigger molecule can pass through. And not just that, it also disrupts the iogenicity of the food processes. Podocyte food processes are generally negatively charged. Albumin pun negatively charged. So because of inflammation ni, dia taklah jadi positif, tapi it becomes less negative. Bila it becomes less negative, bila dia negatif, albumin pun negatif, so dia repel between each other. Tapi bila it become less negative, albumin can easily pass through. So this is what happened. So this is what causes the massive proteinuria. So massive proteinuria disrupts your Starling forces. Betul-betul macam ni lah, you sebut Starling forces, Starling law, baru orang berminat sikit dengar. So disrupts your Starling forces where it reduces the plasma oncotic pressure. Reduces plasma oncotic pressure, relative increment in plasma hydrostatic pressure. So there will be shift of fluid from the intravascular space into the extravascular space, into your interstitium. So there is third space loss. Third space loss into the interstitium, into the peritoneum, into the pericardium, pleural space. So third space loss. So because of this shift, it causes what will happen to the intravascular volume? Intravascular volume will be depleted. It will be underfilled. So this is the classical theory, which is the underfill theory, where there is basically mostly is fluid shift from intravascular to the extravascular space. Now we have another theory, which is the overfill theory. Overfill theory mentions that there is activation of the renin-angiotensin-aldosterone system, RAS activation, and also activation of your vasopressin, also activation of your aldosterone. So all these RAS activation, aldosterone, ADH, vasopressin, all these causes salt and water retention. So bila ada salt and water retention, what happens is the rate of fluid being retained is more than the fluid shift from intravascular to extravascular space. So what happens is there is edema, but there is overfill. There is intravascular volume is increased. Why? Because of salt and water retention. So in this theory, the patient will present with hypertension, oliguria. So this is why you need to know what is the pathophysiology for the patient. Because if your patient falls under underfill theory, you cannot fluid restrict. Kalau you fluid restrict apa jadi? Dia dah underfill. Dia edematous, bengkak seluruh badan. But intravascular volume is depleted. Kalau you buat X-ray, you akan nampak dia punya mediastinum dia shrunken, kecil dia mediastinum dia. Kan? You buat echo, you akan nampak IVC dia kecil. Sebab apa? Sebab dia underfill, under volume. Dia edematous, grossly edematous, but the fluid are all in the interstitium. It's not in the intravascular space. So patient macam ni, kalau you restrict fluid, patient will die. You bagi diuretics, patient will die. This sort of patient, you can give albumin. Tapi you should not give furosemide. Because if you give furosemide, you will cause more intravascular volume depletion and go into shock. Tapi kalau patient yang overfill theory, patient yang dia become edematous, yes, tapi dia intravascular volume dia is over. Increase intravascular volume. BP dia high, heart rate dia low. Kan? This sort of patient, kalau you bagi albumin, what will happen? Fluid daripada edema, semua daripada third space akan masuk ke dalam intravascular volume. What's going to happen? Apa yang jadi?
Heart failure.
Heart failure, hypertension, sebab banyak fluid masuk. Kan? Fluid will be banyak dalam dia intravascular space. So this is why what I'm trying to tell you is you need to know the pathophysiology. Only when you know the pathophysiology, you will know how to manage the patient. Another favorite of mine is actually pathophysiology of asthma. Okay, let's go to AGN. Anyone can tell me what is the pathophysiology of AGN? AGN.
Isn't AGN also inflammation to the glomerular
Yes.
podocyte?
Nope, not podocyte.
The basement membrane, sorry.
GBM, yes. Okay, so what happened?
When there is inflammation there will also be proteinuria because there is increased permeability. Glomerulonephritis.
Orang
Is it because of deposition of immune complex?
Okay, yeah. So you begin a bit earlier. Okay, so again, majority of AGN is post-infectious, post-streptococcus. So you know that the main culprit is group A beta hemolytic streptococcus. For example, streptococcus pyogenes. Kan? This group A beta hemolytic streptococcus, dia ada capability of molecular mimicry. So they have few different strain. Dia ada yang cardiogenic strain. This cardiogenic strain will cause rheumatoid carditis. Dia ada nephrogenic strain. This nephrogenic strain is the one that causes AGN. Dia takkan ada both. So dos yang dapat rheumatic, dia dapat rheumatic. Dia tak dapatlah AGN. Dos yang dapat AGN, dia tak dapatlah rheumatic because they are different strains. Kan? They are different strains. Okay, so what happens is there is infection by streptococcus. Evidence by apa? Sore throat, pharyngitis, skin infection jadi apa? Impetigo, kan? Scarlet fever, kan? So this infection, then the body will produce antibody to fight the infection. Because of molecular mimicry, what happens is the antibody, there'll be antibody complex deposition because they mimic the cells in your GBM, glomerular basement membrane. So there will be antibody complex deposition in your glomerular basement membrane and causing all the inflammatory processes. And these inflammatory processes actually damage your GBM. Dia bukan setakat affect the podocyte food processes je. They damage the glomerulus, the glomerular basement membrane. There will be impairment of glomerular filtration rate and also activation of RAS as well. So that is why there will be salt and water retention, impact GFR and salt and water retention. This causes edema, hypertension, oliguria, and because of inflammation, dekat tubules pun ada inflammation, what happens is dia ada hematuria as well. So oliguria, hypertension, renal impairment, hematuria. So these are the 4 signs that you can see. Sebab tu then you understand the management juga, kan? In AGN the problem is activation of RAS, salt and water retention, and impact GFR. So how would you manage? You would fluid restrict lah. First kali is fluid restrict. No added salt because dia dah ada salt and water retention. So fluid restrict, no added salt. Would you give antibiotic tak?
No.
Bagi ke tak bagi?
No.
So if you look at pediatric protocol for Malaysian Hospital 4th edition, dia kata bagi. Tapi again, kita bagi bukan untuk treat AGN, tapi kita bagi just because we don't know whether there's any other strep yang masih hidup lagi. So because bukan strep tu yang duduk dekat your kidney, it's just the antibody complex yang pergi duduk dekat situ. The antibody complex yang pergi duduk dekat situ. Streptococcus tu dah tak ada dah, mungkin dah mati semua dah pun. It's just the antibody complex. So this is what happens. So if you understand the pathophysiology, you know what you should ask, and you know what are the complications, and you know how to actually manage. Okay. Alright. Any question? Already 57 minutes. I have a patient waiting for me. I can't delay any longer. Sessions with me online usually 1 hour je lah maximum. It's not ideal lah online more than 1 hour, tak boleh lah. Okay, any question? Any question? Boleh tak?
Saya nak tanya doktor. Yang pasal nephrotic syndrome, you mentioned about underfill and overfill theory kan? Both of those mechanisms tu causes dia sama ke etiology dia? Or are they different?
Sama je. It's just how the body responds. How the body responds. Some other, the mainly is just fluid shift from intravascular to extravascular, or the main problem, majority of the problem is RAS activation, salt and water retention. Tapi cara dia present akan differ lah. Sebab kalau dia just intravascular volume depletion, kan, there will be no hypertension. Dia tak akan ada signs of under volume.
How often do you see hypertension in nephrotic syndrome patients?
Less common. More common is the classical theory, the underfill theory. Okay. Boleh? Any other question? Sekolah Okay. Do I have any other sessions with you? Tak ada dah, satu je session with me.
Only one case-based learning.
Okay lah, tak apa. Nanti masa face to face kita discuss lagi ya. Okay, alright. Let's end our session with tasbih kafarah surah As. Okay, let's go.
Thank you,
Thank you, doktor.
Okay.
Thank you, doktor.